Hello, I'm Dr. Mark Mandel, and it's my pleasure today to give a lecture on the treatment of hand injuries in the workplace and the relationship of your job as a claims examiner and the appropriate managing of these injuries. In terms of my background, I'm board certified in general surgery, plastic surgery, and hand surgery. I have performed 18,000 operations in the course of my career as a surgeon, and I performed over 10,000 agreed medical examiner examinations. The AME's job, of course, is to resolve disputes. So the disputes often involve what is the cause of the problem, is this an apportionment issue, is this work related at all, how to manage the problem, and what needs to be done to resolve the problem. And as you know, we're all here because the goal of the workers' compensation system is to help the injured worker. But we need to help them by providing appropriate treatment for these conditions. So what I'd like to do today is start with the fingertip, because we all explore the environment with our hands and it's constantly getting injured, and end up with some brief discussion about shoulder injuries. So our theoretical worker is a sous chef in the kitchen, and he's busily chopping vegetables, and he slices the very tip of the finger off. So this is a very small laceration with a little bit of the pulp present, and the question is, how do you treat this injury? Well, if the injury circumference of the amputated tissue is, say, less than half an inch, or a little over a centimeter in the metric system, the best treatment is to clean the wound, dress it, and leave it alone, because we have a homeostatic mechanism in our body, and injury of this type will heal on their own. So how long does this worker need to be out of work? Well, I would say if his job can be modified and the bandage kept dry, he can return to work in a week. How long does it take for this to completely heal? Probably within 2 months you can rate this particular patient. Now, what if the injury is a little bit more severe? So here we have an injury where he is missing this much tissue. Well, obviously, this is too large a defect to heal on its own, so we need to bring some tissue in to close the wound. Usually for injuries, we put on a thin skin graft, but in the hand, because the thin or split thickness skin grafts end up with a very abnormal looking color, either darker or lighter, or hyperpigmented, we need a full thickness skin graft. So most of these full thickness skin grafts are harvested either from the outside of this area called the hypothenar mass. Sometimes we can take extra skin from the wrist or the antecubital fossa. And the reason is the color match is similar. Putting on a full thickness skin graft, that person's going to be temporarily totally disabled for a minimum of 3 weeks, then return to modified work. But this, of course, is going to take for this to heal completely at least 6 months. But it doesn't mean the person has to be out of work. And what if the injury is even more severe? So there's an injury like this. So now we're missing all of this, and there's bone exposed. So this is too large a defect for a skin graft. So we need to bring tissue in to restore the palmar or volar aspect of the finger. And if the index finger is cut, this means using a flap. So a flap means it full thickness skin, but it brings this blood supply with it. So the most commonly used flaps are called the cross finger flap, in which the defect on the palmar surface is sutured to the back of the long finger, because the skin on the palmar surface is much more important than the skin on the back of the finger. Now these fingers are held together for about 2.5 weeks. They're then severed. The flap has to be inset. The patient ends up with stiffness. So these patients are going to be off work after a cross finger flap for a minimum of 6 weeks, if not longer. And of course, for this to mature completely, it usually takes a complete year before you can rate someone with a cross finger flap. What if he's chopping and the injury is even more severe, and this time he amputates the distal portion of the finger? Well, an injury this distal theoretically can be replanted, but realistically, the chance of replanting this is exceedingly small. So an injury of this type out of the tip is best treated by closing the amputation site. But what if the injury is here? Now he's missing over half of his finger. Well, this should be replanted. Any anatomical part that's amputated should be put in an appropriate bag with saline or salt water, and then put it in an ice bucket. And it should be replanted expeditiously. So usually you can delay for sometimes 24 hours if it's kept refrigerated. Now, in the old days, when I started doing replantation surgery, the success rate was 50%, but that is because the instrumentation, the suture material, was not as fine or sophisticated. Now the success rate should be 90% for a cleanly amputated digit. There are now centers throughout the state, usually university or major hospitals, that have a replantation team. The success rate, 90% for replanted digits. What if the patient, instead of chopping it, his hand goes into a grinder and all 4 fingers are severely mangled? Well, if this had been a clean injury, we would replant all the digits, but if it's a mangled hand with damage to the bones, compound fractures, tendon injury, pulling and shredding of the vessels, a mangled finger cannot be replanted. So it is literally a waste of the patient's time, insurance company's money, because that finger is simply not going to survive. Now, in addition to lacerations, we also have an exceedingly common hand condition called tendinitis. So itis on the end of any word means swelling or inflammation, and that correlates with pain, because when structures are swollen, they're very painful. So for instance, swelling in your sinuses, painful sinusitis, bronchitis, appendicitis. Well, tendinitis means swollen tendons. Now normally, if you look at a tendon, you can see there's a very thin lining around it called the synovium. It kind of looks like the emperor's new clothes. Just kind of looks a little shiny, but really it doesn't have any structure. But in tendinitis, the synovium swells up. Now the function of the synovium is to lubricate the tendons so they glide through the different compartments in our hand. So if the tendon is swollen, they tend not to glide. So here our sous chef slips, falls onto his hand, hyperextends his thumb. So the most common condition is going to be a de Quervain's condition. De Quervain's was named after a physician who died 200 years ago, lived in Belgium, spoke French. And Dr. de Quervain is associated with Dr. Finkelstein, who is a surgeon in Chicago in the 1930s, said, well, if you grasp the person's thumb and you twist it in a little finger or older deviation, that causes excruciating pain, because you're pulling the tendon against the pulley. So in examining the patient with de Quervain's, you don't do a Finkelstein test first, because the patient's not going to cooperate with the rest of the exam. You do the Finkelstein test last. So what is the treatment for tendinitis? Any kind of tendinitis, it's all the same. Immobilization with an appropriate splint, cortisone injections, and job modification. The reason I'm pointing this out is again and again I see patients with tendinitis and they're sent for therapy. Does therapy help tendinitis? Well, possibly, but it's medically improbable. Therapy often makes tendinitis worse, because tendinitis is like an overuse manifestation, so why send the patient to therapy? Immobilization, cortisone, job modification. Now, how much cortisone could we inject? Well, I wouldn't inject any more than 2 injections into one area, spaced maybe 3-4 weeks apart, because cortisone indiscriminately destroys tissue. So if you keep on injecting cortisone, you're going to end up with very thin skin, possibly even a hole, or tendon rupture. So 2 injections. So if the patient doesn't improve with immobilization, job modification, and 2 injections a month apart, that person needs surgery. There's no sending in for never-ending therapy, which I've seen again and again. There's also no indication acupuncture is any value for the core veins tendonitis. I mean, acupuncture is 3 schools: Korean, Japanese, and Chinese. They're all kind of variations of the same theme, but acupuncture is a form of biofeedback where you cause a pain stimulus that causes a reaction in your brain. The brain releases endogenous opioids, and that decreases pain. But for tendonitis, I really see little indication acupuncture is of any value. Now, if the patient does undergo surgery, well, first of all, if you took 100 patients that did core veins, how many patients need surgery? The answer is about 20%. 80% of patients are cured with conservative care, splint, modification, cortisone. 20% of patients need surgery. 90% of the patients who have surgery are much better. The biggest problem is when you do an incision here on the dorsal radial aspect of the wrist, there's a little nerve called the superficial radial nerve, and sometimes that is immediately adjacent to the tendon, and that gets inflamed. So that will cause pain. And if that happens, and that happens maybe 3 to 5% of the time, a cortisone injection is often curative. If not, you might have to do a re-release. Now, de Quervain's is not the only wrist tendonitis condition, it's just the most common. So if the patient falls sort of on the ulnar aspect, the little finger portion of the hand, the second most common form is extensor carpi ulnaris tendonitis. Same treatment, splint, cortisone, job modification, surgery, much less common for extensor carpi. They tend to heal on their own. Now, tendonitis in the back of the wrist is not the only form of tendonitis. Trigger fingers can occur. Now, trigger fingers often follow a specific event, a twist torque or something, but they can also occur on a continual trauma basis. But in trigger fingers, apportionment is often necessary because diabetics, long-term diabetics, meaning 4 or 5 years or more, very high incidence of idiopathic trigger fingers, which means the trigger fingers develop unrelated to their job duties. So in tendonitis conditions, it's really necessary to determine if there are some underlying factors. Now, how do we treat trigger fingers? Basically, somewhat different, but if the trigger is severe, for instance, if the person cannot really, except with a lot of pain, extend his fingers, there's really no sense in injecting it with cortisone. Severe triggering, and that is noted in the recent medical literature, these patients, what's called grade 4 trigger, you can go directly to surgery. If the patient is intermittent triggering, these patients should always be treated with cortisone, and again, not to exceed 2 cortisone injections into one anatomical area due to the fear of tendon rupture. So for trigger fingers, apportionment is applicable, especially if the patient is diabetic or has some sort of a collagen vascular or autoimmune condition such as rheumatoid arthritis. Now, in addition to specific injuries, patients can develop what is called a continual trauma claim. Medically, a continual trauma claim is a series of micro-traumatic events that alters tissue homeostasis. So what that means is, if you're constantly doing the same thing over and over again, the structures will swell. Swelling equals pain. So continual trauma problems do not develop overnight. Most of the classical studies on carpal tunnel were done on assembly line workers or on grocery clerks. So in the old days, almost all the grocery clerks at the check-in counter had carpal tunnel because they used to scan the item by flexing and extending their wrists thousands of times a day. And now if you go to the supermarket, they kind of glide the item across the scanner. So all these risk movements have been eliminated, and the incidence of carpal tunnel has dropped. Now, carpal tunnel has a specific clinical presentation. The patient states, I have tingling and numbness, and I wake up at night and I shake my hands or walk around the room or run to the sink, put them under ice water. That's a history for carpal tunnel. Pain is not a big part of carpal tunnel. If patients have a lot of pain, they may have carpal tunnel, but they've got something else on top of it, because pain and carpal tunnel usually do not occur concurrently. Now, how long does it take to develop carpal tunnel? Usually it takes about a year. So if, for instance, the patient is 3 days on the job and he says, my hands are tingling and numbness and falling asleep, and the nerve conduction study is abnormal, that person had carpal tunnel when he was hired. That carpal tunnel is not due to the new job. That is due to the old job, or perhaps his underlying medical condition. The shortest that I've seen someone develop carpal tunnel has been 3 weeks. And that person was a jackhammer operator. And this constant vibration and pounding against the carpal ligament caused the problem. But generally it takes a minimum of 6 months and usually much longer to develop carpal tunnel. Well, how do we treat carpal tunnel? Patient goes to the industrial clinic, and again, send him to therapy. There's no indication therapy is of any value other than perhaps tendon gliding for carpal tunnel. The correct treatment for carpal tunnel is a carpal tunnel splint, and this is worn at night. The splint is not worn during the day. If the patient wears a splint during the day, they can't move the wrist. Then they use their shoulder to do the activities of the wrist. Then they end up with carpal tunnel and a rotator cuff problem. Splints worn at night. The patients then should have a nerve conduction study. And since most cases of carpal tunnel usually start on the dominant side and then affect the non-dominant, I would recommend a nerve conduction study on both sides. Now, what is a nerve conduction study? Well, a nerve conduction study means we put a stimulus at point A, we send a stimulus down, and we measure it at point B. Now, these are fixed distances, so the same values, whether you're big or small, heavy or thin, are the same. So the normal upper limits of sensory latency for the sensory portion is 3.6. The decimodal latency is greater than 4.2. Now, what if the nerve conduction study is normal and patient states they've got tingling and numbness and night pain? Well, sometimes if you wear a splint for a long time, it will convert a positive nerve study to negative. But in this patient, since we know operating on what are called electronegative patients often results in a bad result, we need to do a provocative cortisone local anesthetic injection into the carpal canal, as described by Dr. Edgell in his classical article. What they did was they injected cortisone into the carpal canal. You have to mix cortisone with local anesthetic because cortisone burns. And they found if the tingling and numbness disappear for days or maybe a week or two and then comes back, that's called a positive provocative test. So patients with carpal tunnel history but electronegative, no surgery unless they respond to the provocative test. Now, can patients have a positive nerve study and not have carpal tunnel? The answer is yes. People can have a markedly deranged nerve study and not have carpal tunnel. So unless the patient has a positive nerve study and positive findings and gives a good history, they're really not a candidate for surgery. Well, how long should we treat the patient conservatively? Well, it depends on how bad the nerve study is and whether or not they have any weakness in their thenar muscles. So if the carpal tunnel is severe, the nerve study is markedly abnormal, there's no sense giving them a splint to wear for a month or two. Those patients need surgery. But if the findings are marginal, wear a splint, inject the carpal canal, and maybe they will never need surgery. Now, what are the problems with carpal tunnel surgery? Oh, but first, let me tell you, how does a nerve conduction study work? Well, we're stimulating it from point A to point B, but the nerves are covered with a special kind of fat called myelin. So what happens is we inject here or stimulate here, and we measure it here, but here's where the nerve is compressed. So what happens? The impulse slows down at that level. So this creates a positive nerve study. So nerve conduction studies are quite accurate. Now, what are the complications and what are the results of carpal tunnel surgery? Well, in the past we used a very big incision, but now almost all releases are either done endoscopically or through a very limited incision in the palm using instrumentation. 90% of patients say, my hand is much better. What does that mean? It means the tingling and numbness of the night pain have disappeared. Everybody undergoing carpal tunnel surgery says, I have trouble doing a push-up and I can't open a twist-top jar. Because when you cut the ligament, you lose some stability in your palm. So if you look at patients who have carpal tunnel release, they don't have that natural curvature. It looks like their palm is flat. So the trade-off is, yes, you don't wake up at night anymore, you don't drop items, but you can't do push-ups as effectively. Now, what about the other 10% of patients who don't have a wonderful result? Well, maybe 5% are no better, no worse, and about 5% might be worse. And they're worse because they have sensitivity at the operative site. And that is almost always due to an injury to what's called the palmar cutaneous nerve. So this is a little nerve that originates from the main median nerve about 5 centimeters from the wrist crease. And then that little nerve supplies the sensation to the thenar eminence. So what happens is the patient, puts their hand down and they get like an electrical shock. Now, that is called somatic pain, or sometimes it's called causalgia, which means burning pain. But you can also call that as complex regional pain syndrome 2. So complex regional pain syndrome 2 is a local form of pain and it is treated locally. The treatment for that condition is cortisone injections to decrease swelling around that little nerve, or if the nerve is inadvertently cut, it may be necessary to reopen the area, take that little nerve and bury it between the two bones. But that is not complex regional pain syndrome 1, which is previously called reflex sympathetic dystrophy, and numerous other names. So a group of scientists and physicians got together in Budapest, and they came to give a list of criteria to diagnose complex regional pain syndrome 1. And those are also similar to the findings in the guides, 5th edition. Now, complex regional pain syndrome 1 is global pain. It's not local pain. This is local pain, complex 2. It's global pain. Nobody knows exactly what happens. It's some kind of a bizarre reaction in which the noxious stimulus or injury site causes the pain impulse to be magnified tremendously and also to cause abnormal findings. So the patient is opposed to having sensitivity in the local area, the whole hand becomes painful. It could be swollen, it can drip like a rainforest, it could be bone dry, it could be ice cold, it could be hot. And eventually, the hand becomes atrophic, or you lose complete function if a real case of complex pain goes untreated. So how do we treat complex pain 1? Aggressive therapy. There should be no delay. Once the treating physician says the patient has a pain perception problem, they need aggressive therapy. I don't mean 3 times a week for 2 weeks. I mean probably many, many, many weeks, and maybe on a daily basis, because you can actually break the pain problem with aggressive therapy. What if they don't? Well, in that case, I think you need to do a 3-phase bone scan. And in the delayed phase, you can see abnormal pooling of blood. That's pretty well specific for complex pain. But before that, the patient should have x-rays of the hand, because patients with complex pain 1 have a very unusual distribution. They get what are called juxta-articular osteopenia, which means Around the knuckles, all of a sudden the area decalcified. So X-ray wise, that is one of the hallmarks. Pain alone doesn't mean you have complex pain. But what if you have all these abnormal vasomotor problems? Then you need pain management. So if the patient really has complex pain, one, you need pain management. And I would start with some stellate ganglion blocks. But aggressive therapy is really the initial way to treat this condition. Now, fortunately, complex pain, one, is relatively infrequent after carpal tunnel, less than 1% of patients. Now, apportionment in carpal tunnel is always important because diabetics, people with long-standing thyroid disease, patients with autoimmune rheumatologic conditions, all have a very high incidence of carpal tunnel. So if the patient is diabetic, has changes on the nerve study indicating a diabetic polyneuropathy, here apportionment is really critical. Because sometimes people can develop carpal tunnel absent any industrial exposure at all. So for continual trauma claims such as carpal tunnel, apportionment is always an issue. Now, for every 10 cases of carpal tunnel, we have 1 case of cubital tunnel, which means the ulnar nerve, as it goes around the inside of your elbow, is compressed. So cubital tunnel is mostly a stretch injury of the ulnar nerve as it goes around the inside of your elbow. Now, the patient is complaining about tingling and numbness, usually in little ring fingers, because that's the ulnar nerve distribution. They go to the industrial clinic and they start them on therapy. Well, therapy is not the answer for every condition. It's the answer for some conditions, but not cubital tunnel. Because one of the ways clinically we diagnose cubital tunnel, in addition to irritability, loss of sensation, is we have the patient do a flexion and extension test. And usually the patient with cubital tunnel, if he does that 10 times, they get increasing tingling and numbness. So sending the patient to therapy for cubital tunnel, incorrect. The correct treatment is give them a splint. Not just any splint, they need what is called a pillow splint or something similar to it. A pillow splint allows the patient to extend their arm. See, this relaxes the ulnar nerve. But if you really flex your arm, you're stretching your ulnar nerve against the bone, and that increases the symptoms. So the pillow splint lets you come to neutral, but it doesn't let you flex completely. In the old days, we gave them a rigid splint, but these were so uncomfortable, patients rarely wore them. So therapy is not the answer before surgery for cubital tunnel. Now, the pillow splint or something similar needs to be worn for months. Wearing it for a week is not going to make a difference. The splint is only worn at home and at night, usually for 3 months. How many patients will improve? Well, about 70% of patients will have the problem improve or disappear using a pillow splint if the problem is relatively mild. About 30% of patients may eventually need surgery. Now, the nerve conduction study is not as accurate at the elbow as it is for carpal tunnel at the wrist. So the accuracy of the nerve study is well over 90% at the wrist level, but it's only about 70% at the elbow. So a lot of patients with cubital tunnel may be electronegative. But cubital tunnel is tingling and numbness in these fingers. If they fail conservative management for 3 months and they're still electronegative, one could order an MRI. But generally speaking, these patients need surgery. In the past, many operations were done, including knocking off the medial epicondyle, moving the nerve to different locations, putting the nerve in the muscle, putting the nerve underneath the muscle. But recent evidence indicates simpler is better. So a limited release is often curative. So of the 30% of patients who undergo surgery, about 20% of those patients end up with a sensitive scar, because just like there's a little nerve at the wrist level, the pompocutaneous nerve, there's a little nerve here at the elbow that supplies sensation to the inside of your elbow, and that's called the medial antebrachial cutaneous nerve. So medial just means close to your body. Anti before brachia of the upper arm. So it's a little nerve that supplies sensation to the elbow. Cutaneous means skin, and nerve means nerve. So 20% of patients will end up with some sensitivity. So when you rest your elbows on the table, well, that's kind of uncomfortable. Well, there are all degrees of discomfort. If it's a little uncomfortable, leave well enough alone. If it's really uncomfortable, try and locate the area of maximal sensitivity, inject it with cortisone, the local anesthetic. But if the problem is severe, the patient's going to need a re-release of the ulnar nerve of the elbow. Less common than cubital tunnel, with an incidence of 1 case for every 200 cases of carpal tunnel, we have thoracic outlet syndrome, which was given its name by the surgeons at the Mayo Clinic about 40 years ago. Now, before that, it had numerous names: scalenus antecus syndrome, arm-shoulder problem, blah, blah, blah. Anyway, it's interesting that before Dr. Phelan in Cleveland described the Phelan's test, which means you put your hands palm reflexed and tingling and numbness occurs in the median nerve distribution in less than 30 seconds. People with carpal tunnel were actually getting their ribs resected and their muscles transected, and most of them weren't any better because they didn't have thoracic outlet, they had carpal tunnel syndrome. But now we know that thoracic outlet means the nerves are compressed somewhere between the nape of the neck and your axilla. 3 types of thoracic outlet. There's arterial, which is about 3%, venous, which is about 3%, and the other 95% is called disputed thoracic outlet. So arterial and venous usually are acute. So who gets one of those conditions? Well, I'm riding on my motorcycle and some jerk rear ends me, knocks me off my motorcycle. I fly over the handlebars. I land on my shoulder, massive swelling here, and I lose my pulse. So that's something that has to be treated right away. And it's pretty easy to diagnose. Pulses are weak, the hand is ice cold, patient's in a lot of pain because there's no blood going. So that's arterial. Venous, the hand is blue and swollen. So arterial and venous are mostly acute injuries. They can occur in the workplace, but I would say they're mostly accidents that occur secondary to either skiing and other similar sports or from motor vehicle accidents. So we're left with the lion's share of patients with disputed thoracic outlet. And it's disputed because a lot of people don't think it's work-related. Now, when I was in training many years ago, I went to the surgical office, and the secretaries, all properly groomed, I might add, were sitting in perfect position, working on their IBM selective typewriter, perfect posture, wrist neutral. These patients never got carpal tunnel. Indeed, carpal tunnel was not that common an entity 30, 40, 50 years ago. And now it's exceedingly common. And thoracic outlet was really literally unheard of on a work-related basis. But now, we're on a computer, so we're kind of slumped over the computer. So what are we doing? We're doing a costoclavicular maneuver. See, we're decreasing the space. So the treatment for disputed thoracic outlet is job modification, providing the patient with an ergonomic correct workstation. Here, they do need therapy to enhance the use of certain muscles so they don't slump over the table. And most of these cases will improve. Surgery for thoracic outlet results vary considerably. So, being certified in general surgery many years ago, I did thoracic outlet surgery. And the results were not exactly wonderful, but if you talk to the vascular surgeons who can now do some of these things with endoscopically, the results are a little bit better. But I see them as an AME, and it is indeed the rare patient that I see, and I see these routinely, who says, that thoracic outlet surgery, they removed one of my ribs and cut my muscles, and was a wonderful procedure. So surgery for thoracic outlet is sometimes necessary, but the patients need to carefully weigh the advantages of the surgery against the results. But fortunately, most disputed thoracic outlet can be treated conservatively. So we're back with our kitchen worker, and this time he slips and falls onto his outstretched hand, and he has a lot of pain. So he goes to the industrial clinic, and you see the diagnosis, strain sprain, strain sprain. So what does that mean? Is a strain the same as a sprain? And the answer is no. So if we look at our worker's wrist, a sprain means that the ligaments between the two bones is injured. So this is the scaphoid and the lunate. And this is one of the most common tears of the ligaments in the wrist. Now, so this is a sprain. Now, sprains come in all degrees of severity. Mild, which means microscopically there's torn structures and some swelling. Moderate means it's a partial tear, and severe means it's a complete ligament tear. So you need a pretty significant force vector to completely tear your scapholunate. It's a very strong ligament. Now, how do we diagnose the condition? Well, first, for any wrist problem of a ligamentous nature, it's necessary to x-ray both wrists, because a lot of people have separation of the scapholunate and it's just a normal variant, and that occurs about 10% of the time. The reason for pointing this out, I've seen many cases who do not have a tear, who have undergone surgery to repair a gap. But if you look at their asymptomatic wrists on the left, they're the very same gap. So it's necessary to x-ray both wrists, because 10% of people are going to have problems that look like they have a ligament tear. How do we treat this? Well, first, therapy is not the answer. So sprain, strain, why send them to therapy? They already have a problem, a mobilization. Now, one way to determine what is going on, because we don't know sometimes is the problem, is it inside the wrist or is it outside the wrist? Is it decorative veins or a ligament tear? Is you just have to inject the wrist with local anesthetic. And if the pain disappears, we know the problem is inside of the wrist. Now, what usually happens is the patient goes to therapy. Sure, they give them a splint to wear at home, but wearing a splint part of the time in therapy, the other is counterproductive. Then the patient doesn't get better, so they say, we need an MRI. So we need authorization, so that takes a while to get. Then the results of the MRI are equivocal, because the accuracy of the MRI is only 80%. So then we need an MRI arthrogram. So now, we're 3-4 months down the line, and the patient really isn't any better. And again, we don't know what to do. So the next step is, well, we need to scope the wrist or take a look inside. But if you inject the wrist with local anesthetic, the pain disappears, and if he has a plain film that suggests it, and his history goes along with a scapholunate tear, meaning his tendon over the air, and there might be some clicking and popping, that patient should undergo arthroscopic debridement, and then they don't need the MRIs or the MR arthrogram. Now, in addition to this scapholunate, one of the most commonly injured structures is the triangular fibrocartilage complex, or the TFCC. Studies on patients with no wrist pain in the 45-year age group, but a significant number, 50 to 100, noted that 25% or more of people without any wrist pain have tears of the TFCC, because this is like fibrocartilaginous. So simply having an aberration on an MRI doesn't mean the patient needs surgery. So unless the patient's clinical presentation correlates with the diagnostic study, surgery should not be authorized. Because when you go into the wrist with a scope, there's always a chance the patient may end up with significant stiffness, or he can actually damage one of the other structures. So I would recommend wrist pain. An injection into the wrist is a diagnostic study, probably more accurate than an MRI, even an MR arthrogram. Now, one of the least understood conditions is lateral epicondylitis, also known as tennis elbow, and its other problem on the inside, medial epicondylitis, or golfer's elbow. So tennis elbow was described many years ago, people playing lawn tennis in England, having a jolly good time, and they noted they had pain in their elbows. But if you see people playing tennis now, or now pickleball, they're all wearing a compression strap, a counter-force brace. And that is indeed the correct treatment for lateral epicondylitis. Now, as opposed to tendinitis, which is swelling and inflammation of the tendons, there is no itis in lateral epicondylitis. The reason for pointing this out, there's no indication cortisone injections are of any value for lateral epicondylitis. But if you were in your training program years ago and they said, cortisone, tennis elbow, I see many patients, many doctors still doing it, but numerous studies have been authored by presidents of the American Society for Surgery of the Hand, and all of them say it's a placebo value only. Now, how many patients need surgery with tennis elbow? Only about 10%. Most patients with tennis elbow heal on their own. So whether you use massage therapy, occupational therapy, physical therapy, active therapy, cortisone injections, ultrasound, or platelet-rich plasma, which I'm going to discuss in a minute, almost all these patients get better, but it takes about a year. What happens in tennis elbow is, as opposed to tendinitis, the extensor muscles pull off the bony origin. So instead of muscle attached to bone, you have muscle scar tissue and bone. So when you dorsiflex your wrist to go into a power grip, that's pulling on the origin of the extensor muscles, and that causes pain. So how do patients with tennis elbow present? They present with a loss of grip strength. So you look at the Guide to the Evaluation Permanent Impairment 5th edition, one of the areas that cannot be quantified other than using the strength loss index is tennis elbow. Now, what if the patient doesn't get better after, say, 6 months? Then they're a candidate for surgery. Now, the surgery can be either be done arthroscopically or through a limited open approach. And in the workers' compensation realm, and I might add that generally speaking, workers' compensation patients do not do as well with elective surgery as patients who do not have workers' compensation problems. And maybe that's because they're litigated, or maybe it's because they're not paying for the surgery, so in a private patient there's more stimulus to sort of get back to activities. But if you did 100 patients with lateral epicondylitis, 60% of patients would say, wow, that's a really good operation, it really helped. 20% would say, well, I'm no better, but I'm no worse. And 20% would say I'm worse. Because sometimes to fix this, you have to sometimes drill some holes in the bone, you have to reattach it. Patients end up with stiffness or a sensitive scar. So in terms of the treatment for lateral epicondylitis or tennis elbow or its friend on the other side, medial, I would recommend conservative treatment. And again, here, a counter-force brace and the pillow splint are most beneficial. So our sous chef slips on a piece of lettuce and he falls onto his outstretched arm. We've taken care of the wrist problem. We know he has torn a ligament. And when you review enough of these reports, the patient goes to the clinic or even the hospital and they treat the wrist. But what happens if you fall with enough force to tear a ligament or fracture your wrist? That force vector is transmitted up to your shoulder. And the shoulder is an unprotected joint. So about 10% of patients with a significant wrist problem have a secondary problem in their shoulder. Because any joint that moves in every direction, be it shoulder, hip, or thumb, is basically unprotected, as opposed to your fingers, see, which go back and forth, but the ligaments here are really strong, or your knee goes back and forth. But anything that goes round and round is more prone to injury. So what can happen? Well, there are basically three basic types. And the first is you can dislocate your shoulder, and most of the dislocations are anterior, pretty painful. You can actually see the head of the humerus popping out. The emergency room physicians are very well trained. They can reduce this, immobilize the patient in a sling, and that patient will probably have to miss at least 2 to 3 weeks and then return to modified work. But if it dislocates again or again, the patient's going to need surgery. But that is not one of the more common problems. More common is what's called the labral defect. Now, if you look at your shoulder or shoulder schematically, the shoulder joint is like a golf ball sitting on top of a tee. Now, the golf ball is the head of the humerus, and the tee is your scapula. So the inside of the scapula is called the labrum. So if you're making a big pot of soup, you toss some bones in. When you look at the bones, they have a shiny surface. So the shiny surface on the inside of the scapula is called the labrum. And the different types of injuries include a labral tear. The most common type is called a SLAP, which is an acronym for superior labral anterior posterior. And the injuries come, of course, in all degrees of severity. Any type of a shoulder problem other than dislocation should be treated with therapy. So that's in the medical treatment guidelines. Many of them, since we have a healing ability in our body, will heal or become asymptomatic. But if the tear is significant, I would inject some cortisone. If that doesn't help with therapy, the patient needs an arthroscopic repair. And that can be done either by repairing the tear in the labrum, or since the long head of the biceps inserts in the labrum, some physicians like to release the long head, causing a Popeye deformity, and that is often curative for a labral tear. Far more common than labral tears are rotator cuff disease. So that can either be in the form of tendinitis or swelling, or you can have a partial tear. Now, one has to be very careful about overinterpreting MRIs of the shoulder. In a very classical study done years ago involving hundreds of patients with good medical histories, with no complaints in their shoulders, they found on autopsy studies that over 50% of patients had either complete or partial significant tears of the rotator cuff. Because the rotator cuff inserts on the front of your humerus and its fibrocartilage. As we grow older, the liquid or the water content decreases and it tends to crumble. If you look at what powers the shoulder, it's the four muscles comprise the rotator cuff. So the most commonly injured is the most superior muscle called the supraspinatus or the suprascapula. The reason why that's injured is most frequently is because it's the smallest muscle and has the poorest blood supply, so it's more prone to injury. The others are less common. So when you see the surgeon diagnosing complete rotator cuff tear, a lot of times they're talking about the supraspinatus, and the other elements are intact or partially torn. Again, even with a complete tear, therapy is still the answer. The treatment involves scapulothoracic strengthening, improving motion, and then if the patient is recalcitrant to conservative care in the medical treatment guidelines and cortisone injection, they need surgery. And if it's only the supraspinatus, that can be repaired because the other muscles are intact, so that may or may not retract. there isn't really time to go into the more severe injuries like a complete tear, but if all four muscles are torn, they tend to retract, and this is very difficult to repair. So I think it's beyond the scope of this talk to go into graft jackets and capsule reconstruction or total reverse arthroplasty procedures. But if the patient is a complete tear, they usually develop arthritis and they need a salvage type of a procedure. So I'd like to conclude the talk by saying there are different types of injuries, specific injuries. There are continual trauma problems that take a considerable period of time to develop. It's important to differentiate between the two types of injuries. In assessing any of these patients, we have to take in consideration various apportionment factors. What is the role of diabetes? Are they pre-diabetic? Are they short-term diabetic? Are they long-term diabetic? Do they have thyroid disease, which is often a factor? Do they have an underlying autoimmune disease? Is the problem old? Is it due to the old employer? Is it due to the new employer? So as your job as claims examiners, it's important to understand the clinical conditions, understand how long it takes these conditions to heal. And as an accompaniment to this lecture, I've also prepared some short articles on the treatment of upper extremity injuries. And I've also showed how long, generally speaking, although cases vary individually, how long it takes for someone who works in an office setting and someone who does heavy duty construction to return to work with the various conditions. So I'd like to thank everyone for listening to this lecture. I appreciate your taking the time out of your schedule. I'm Dr. Mark Mandel in Beverly Hills, and I function primarily as an agreed medical examiner. Thank you for your time.